Okay, so let's begin. So I entitled this lecture as Antiretrovirals 101, Understanding How ARVs Work. So before anything else, we have to know why ARVs are important. So here we see a chart showing us the impact of highly active antiretrovirals on survival among patients living with HIV. The pink line here shows us that before ARTs were available, the average lifespan of someone with HIV was only until this age. So ito yung survival nila from age of 25. So ilang years lang yung tinagal ng kanilang buhay from diagnosis at age 25. And here we see that as the modernization of ARVs progressed, mas humahaba ang survival ng patients natin. The only data here, the latest data is of the late ARVs, which we have in the Philippines, ang tawag is late ARVs, no? In 2005. Compare mo siya sa population control. So ito yung mga tao na walang HIV. But as I will show you later, we have a lot of new developments in our ARV. So we expect that the actual lifespan is actually longer. Oh, may poll muna tayo. By the way, ito si Pammy. I'm sure you know Pammy. Okay. Question, and please answer. What are the goals of treatment in HIV? Please choose all that apply. So if you think more than one ang answer, click ka. As many as you can. Vote na po tayo. So we'll give us mga 10 seconds. Sige, vote lang ng vote. Kahit maka 50% lang tayo, guys. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. Okay, so ito yung ating results. Okay, so here we see na kalat, no? Many of you believe that actually almost all of the choices are the goals of treatment. So let's see kung tamang sagot natin. So ito yung treatment goals, no? Tama ang sumagot ng all of the above. Maximal, ito actually number 1, no? Maximal and durable suppression of plasma HIV RNA. If this sounds too highfalutin, it only means to make the patient undetectable, no? I-suppress ang viral load. Next, to restore and preserve immunologic function. To make your immune system function as it should be, so dapat ma-protect niya yung katawan ng tao against infection. Number 3 is to reduce HIV-associated morbidity or remove the complications as much as possible, prolong the duration and quality of survival, correct? And prevent HIV transmission. I'm so happy to see that many of you chose this kasi very latest lang yung data on this na actually taking ARVs can actually prevent HIV transmission. So ito yun, ano? The risk of HIV transmission through condom-less sex when HIV viral load is suppressed or if the patient is undetectable is 0. I think nasa pre-test ito. So whether it is a relationship among men with another man or man with a woman, it is 0 risk of transmission. So we're happy to hear about this, no? It gives the patient peace of mind and less guilt regarding transmission. So before we know about how ARVs work, we actually have to know what the virus is like. So this is a simplified structure of HIV para lang alam natin anong parts ang magiging factor during the treatment. So it's important to know these things. So sa labas ng envelope ng HIV ay meron tayong mga nakalawit na proteins, no? GP120 and GP41. If you look closely at your patient's Western blot, yung official result from the San Lazaro SACL, you will see the boxes at the bottom and you will notice that there is a box for GP41 and GP120. Kasi itong mga part nito ng viral envelope ay actually one of the things na nire-recognize ng Western blot test. No? The presence of that, along with other proteins, will indicate the presence of HIV in the body. Now, inside the capsid are the most important parts of the HIV virus kasi nandito yung mga enzymes na kailangan niya to make another HIV virus. Okay, let's begin. Ano ba yung cycle na to? So first, okay, alam natin na ang target ng HIV virus is yung CD4 T cell. So maghahanap siya ng CD4 T cell na merong CD4 receptors. Kailangan merong pang-connect. No? Kailangan mag-attach sila sa isa't isa before magkaroon ng replication. So the GP120 fuses with the CD4 receptor. And after that, kailangan pa ng isang co-receptor. So hindi lang isa ang receptor ng HIV. So itong co-receptor is either a CCR5 or a CXCR4. Okay? So pagka-attach ng virus sa CD4 T cell, siya ngayon ay yung envelope niya mag-fuse sa cell wall ng CD4 T cell. Mag-fuse, no? Remember the word fusion, important yan. Tapos, tsaka papasok yung laman ng virus, yung capsid into the cytoplasm of the CD4 T cell. O, ano nangyayari pagkatapos nun? Ito na ang tinatawag nating reverse transcription. So, special yung HIV virus kasi kaya niyang mag-synthesize ng DNA from RNA. So, if we remember yung mga lectures natin ng biology, DNA should produce RNA. Pero ito, meron tayong reverse transcription. Kasi meron siyang special enzyme na to. So, using yung RNA niya, gagawa siya ng DNA. Okay? Sa cytoplasm pa siya nito. After which, kailangan pumasok siya dun sa host nucleus. Okay? Papasok siya dun. Yung DNA na ginawa mo kanina, ginawa niya kanina. And using this integrase enzyme na baon niya sa kanyang capsid, i-integrate niya o ipipilit niya yung sarili niya sa host DNA. So, kailangan maging part siya ng host. Okay? After that, yung gagamitin naman niya ngayon yung enzymes, no? Gagamitin niya yung enzymes ng CD4 T cell para magagawa siya ng messenger RNA. So, user siya. So, ginamit niya yung supply si CD4. Let me use you to make my messenger RNA. So, ito ay mahahabang chains of HIV protein. Hindi pa siya usable ha, kasi mahabang chains niya. So, kailangan niyang gawin ay gawin niya into efficient small HIV proteins. Okay. So, paano niya ginagawa yon? Ayan, itong purple na box na to, ito yung protease enzyme. It acts as a scissor. Kinakat niya yung long protein para i-send out niya into the world. So, HIV proteins are cut into smaller chains by protease enzyme. And then, mag-a-assemble siya ng sarili niyang envelope. No? Magpo-push out siya sa ginamit niyang CD4 T cell. Tapos magkakaroon siya ng sariling envelope. And then, tulog siya nito. Okay. Paglabas niya sa CD4 T cell, inactive siya. Kailangan siyang ma-activate para maging infectious. So kaya hanggang ngayon, medyo mahirap yung cure kasi marami pa tayong latent or tulog na virus na hindi kayang i-eliminate ng mga existing natin na gamot. Kapag itong mga latent virus sa mga reservoir cells natin ay nailabas no, at gisingin, pwede na tayo makahanap ng cure. Pero we're still making that work. So I hope medyo, although super simplified, medyo clear kung paano gumawa ng virus. Kasi remember, itong mga steps na to ang actual target ng mga gamot natin. Okay, so to summarize, there are 4 important steps in the life cycle of HIV. Entry, reverse transcription, integration into the host DNA, and proteolysis or gupit. So here we can see kung saan nagkakaroon ng areas ang mga gamot para ma-prevent ang replication of HIV. Pwede mong harangan yung entry using your entry inhibitors. Pwede mong harangin ang paggawa ng DNA using your reverse transcriptase inhibitors. Pwede mong pigilan yung pag-integrate niya into the host nucleus using your integrase inhibitors. And pwede mo siyang pigilan na gumawa ng effective proteins by stopping the scissors or protease inhibitors. Okay, next. Now that we're familiar with our replication process, let's now see where our medications act. Paul time! Hi, Pammy. You're so cute. Okay. Are you guys ready? Poll number 2. So the ARTs available in the Philippines under the National HIV Program have action on the following steps that we mentioned in the HIV replication. So choose all. Alin sa tingin nyo ang mga steps na kayang pigilan ng mga gamot natin dito sa Pilipinas? 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. And okay, so here we see that majority of us answered na reverse transcription, orange. Although everybody, the rest can believe na meron tayong gamot for attached social. Okay, sige. Noted, noted. Okay, sige, pag-usapan natin yan. Hirap pag-multitask. Okay, game. Okay, so first, pag-usapan natin yung kinlick nyo na orange. No? Ito yung mga reverse transcriptase inhibitor. So tama kayo. Ito ang, meron tayo nito. So meron tayo nito. No? Excuse me. There are 2 types of reverse transcriptase inhibitors. Yung tinatawag nating nucleoside and non-nucleoside. So ito yung picture natin kanina, no? Paano nangyari yung reverse transcription. So dalawang areas of where meds can react are present here. Itong orange na to, ito yung ginawa ng reverse transcriptase na bagong DNA from RNA. Pag nucleoside reverse transcriptase siya, itong chain na to na bago ang mismong pipigilan niya. See here? So the inhibitor, the reverse transcriptase inhibitor, puts an end to the new DNA chain. Stop it, sabi niya. You cannot move anymore. So ito yung ginagawa ni tenofovir, lamivudine, abacavir, zidovudine, and emtricitabine. So itong iba, wala na yan. X na yan. Kasi toxic sila. But 1, 2, 3, 4, 5, we have that here in the Philippines. So they terminate the DNA chain. Okay? So, ano naman yung non-nucleoside? Okay. Ang non-nucleoside ay they act on the enzyme itself. So, wala siyang pakialam sa chain na ginagawa. Pinipigilan niya yung enzyme mismo. Sabi niya, stop it. So, the enzyme cannot produce the viral DNA. Ito yung trabaho ni efavirenz, nevirapine, and ni rilpivirine. Okay? So, wala tayo nitong delavirdine and masyadong bago tong si doravirine. So, wala pa siya sa atin. Yan trabaho nila. It stops the enzyme from creating more DNA from the RNA. Okay. If you answered protease inhibitor or yung sa scissors, tama kayo. Meron tayo niyan. So, ito yung actually ating lopinavir, ritonavir. So, it's a combined medication, boosted. Yung ritonavir alone is not useful. So, ritonavir combined with lopinavir, ritonavir boosts the efficacy of lopinavir to make it efficient. So, what it does, so ito yung scissors, no? Ginugupit niya yung mga long proteins into small, usable proteins. Siya yung thumbtack. So, parang point, you cannot cut anymore. So you are left with long, inefficient proteins, which then cannot bud out of the virus. Okay? So yan yung ating second line, protease inhibitors. Yan ang trabaho niya. Ngayon, ito wala, well, meron tayo dati pero wala na ngayon. No? It's the integrase inhibitors. Ito yung pumipigil sa integration of the protein into the host DNA. So it blocks the insertion of DNA of the HIV into the CD4 cell DNA. We have raltegravir, we have cobicistat and elvitegravir, dolutegravir, which is super sikat, and bictegravir. So later we'll see, sino ba to si bictegravir? Actually, siya yung pinakabongga ngayon. First line siya sa ibang bansa. Okay? Now, you mentioned earlier that we have entry inhibitors. So sadly, we don't have this. No? Ito yung tinatawag natin na sinastop nila yung virus from attaching to the CD4 T cell. So pag hindi ka naka-attach, hindi ka na makakagawa ng further. So there's a lot of areas here where you can stop it. You have the CCR5 antagonist of Maraviroc. Kaso, it needs a viral co-receptor. So parang marami siyang requirements para magamit mo yung Maraviroc. Kailangan CCR5 yung co-receptor niya, hindi CXCR4. Diba? Dalawa yung co-receptors ng HIV. So dapat CCR5. Studies have shown that it is actually non-inferior to EFAV. Non-inferior. It is not non-inferior. So, ibig sabihin, mas magaling si efavirenz. Isa pang klase ng entry inhibitor is yung enfuvirtide. It is a subcutaneous injection. It blocks the fusion. So, di ba, after attachment, mag-fuse yung envelopes nila. So, oops, hindi na tayo mag-fuse. Therefore, hindi ko mapasok yung aking capsid inside the cytoplasm. So, the cycle stops there. Okay, so that's just a very simplified definition of what the classes of antiretrovirals we have and what are the most common examples. So now, let's now go on to choosing what regimens to start when we want to do to start ARVs in our patient. So, ang kailangan una, the meds should work. So, ibig sabihin, you have to work with a drug-susceptible virus. Kailangan effective siya. Kasi kung hindi, di baliwala. Number 2, gumagana nga yung gamot mo, but are the patients taking them? So, this is an issue of access. Do we have the meds? Number 2, adherence. Iniinom ba siyang araw-araw to reach the optimum adherence rate? And number 3, drug optimization. So kung toxic yung drug, maraming side effects, o mabigat yung pill burden, hindi mahuhumaling yung pasyente sa regimen niya. So even though it's there, I want to be adherent, but it makes me vomit all the time or I can't concentrate, hindi tayo makaka-expect na maganda yung adherence ng patients natin. So, again, a drug-susceptible virus, there should be access, adherence, and the meds should be tolerated. Let's talk about the drug-susceptible virus. Do you think ba na lahat ng gamot natin dito sa Pilipinas ay kumbaga, susceptible yung virus ng Pilipino sa kanila? So, lately, we've seen a shift in the subtype. So, let me make it clear na hindi ito strain. Okay, this is just a subtype. No? So, maraming subtypes ng HIV-1. And dati, yung most common natin is B. Lately, we have more of the AE, CRFAE1 type of virus. So what is the relevance of this shift? So here we notice that this actually is also present in the countries of China and Cuba, that there is increased frequency of mutation of the virus. There is cross-resistance. There's a bigger reservoir or yung latent virus na tulog, okay? And there's faster disease progression. So imbes na ma-expect mo na the patient with HIV will progress to AIDS in about 8 to 10 years, actually 3.5 years to 5 years, pwede nang mag-progress to AIDS ang isang pasyente. So, ang bilis, di ba? So, what else? So, yung transmitted drug resistance ng Pilipinas. So, what do you mean? So, Dr. Salvania will talk more on this in his next lecture. Pero what we mean by transmitted drug resistance is yung nakuha mong, wow, what's this? Writing on, who's writing on my screen? May vandalism na nagaganap. The transmitted drug resistance is already at 9.7 to 19.5%. Ito yung virus na nakuha mo ay resistant na. Okay? Because it came from someone who already has resistance. So, pwedeng kunyari, example patient who developed resistance while on treatment kasi poorly compliant siya. So, resistant yung virus niya. And then he stopped treatment. And then during that period na nag-stop siya ng treatment, naipasa niya yung virus sa ibang tao. So yung nakuha ng virus na yon actually now has transmitted drug resistance. Acquired drug resistance is also 10%. So ito yung mga problems natin sa compliance, no? Pag hindi ka nagkakaroon ng good adherence. So mataas. So what does this mean? It means, bottom line is, parang may value na meron tayong baseline genotyping. So alam ko mahirap to at hindi lahat ng tao kayang i-afford ang baseline genotyping, pero because of us doing some studies, no, minsan may mga pasyente kami na libre yung baseline genotyping, and it's surprising to see na marami ang resistant na at baseline. Okay? So I think if we cannot do baseline genotyping, maybe we should really invest in viral load. And if possible, an earlier viral load kasi ang naging habit natin is viral load at 1 year. So that might be too late already for some people. So in other countries, the viral load is done ideally at month. So at baseline, after 1 month, at month 3, at month 6, and then quarterly. Kasi meron silang, they can afford it. Pero here, at least siguro mag-month 3 ka ng viral load para if your patient actually has drug resistance at baseline, makapag-shift ka na earlier. So, more on resistance on future sessions. So, hindi tayo mag-stay doon sa topic na yon. So, ano pa ba ang kailangan para sa isang ARV? So, kailangan optimized. Ano ba yung mga optimization criteria? Kailangan high virologic potency. Sabihin, it does what it should do. It should suppress the virus. Number 2, low toxicity. Number 3, high genetic barrier to resistance. So what does this mean? Kailangan niya ng more than 1 mutation bago siya mag-resistance. So ang ating mga NRTIs, NNRTIs, unfortunately, only need 1 mutation to be resistant. Whereas yung second line natin, yung lopinavir-ritonavir, requires 6 mutations. So, the higher the genetic barrier to resistance, the better. Ibig sabihin, hindi yung nag-miss ka lang ng ilang araw, resistant ka na. Kailangan, matibay. Next, your regimen should be simple. Paano? Ideally, it should be available as generic, fixed dose combination. So, ang ating gamot na 3-in-1, LTE, perfect yan. It's very simple. Generic, sabihin mura, and 1 pill a day. Low pill burden, important yan. So, ayaw natin na maraming pills ang tinatake ng patient kasi it's either they will forget because it's taken more times a day, or mayroon silang pill gastritis, mahirap lunukin, nakairita, ganun. Harmonization. So many of our patients have other stuff going on. So yung ating ARVs dapat pwede gamitin sa buntis, pwede sa bata, especially in the Philippines, pwede sa TB, and few drug interactions. And lastly, cost. So mas maganda na ang ARVs ay mura. So ito yung ating wish list. Of course, not all drugs will check this checklist. Pero kung gagawa ka ng magandang drug, kailangan meron tayong optimization profile. So here we see that some drugs like dolutegravir have a lot of checks in the optimization profile. Itong use in pregnant women, check na yan. No? New data shows that dolutegravir is actually safe in pregnant. Itong use in HIV-associated TB, check din yan. Kaso lang, it means a higher dose of dolutegravir. And then efavirenz at a lower dose, ito yung kanyang darunavir, ritonavir, and raltegravir. So these are the more, let's say, the major new ARVs and their optimization criteria. So now let's talk about yung local guidelines natin. So from here on, I will share with you our local guidelines on ARVs, and most of you already know this and have copies of this PDF or PowerPoint. So ano ba yung mga strategic approaches to control HIV? Test early, treat early, and treat all. So we don't have CD4 limitations. Dati meron, ngayon kahit ano pa yung CD4 mo, kailangan mo mag-start ng ARVs. So the objective of our guideline is actually to remove the limitations on eligibility for ART among Filipinos living with HIV. So we're going to make it super easy and barrier-less for people to be on ART. Kasi kailangan natin yan. So first guideline, ART shall be initiated in all persons with confirmed positive HIV test result regardless of clinical and immunologic status. So may mga possible questions siguro kayo about this, no? Kailangan ba hawak ko na yung Western blot ko kasi confirmed positive HIV test result? So the answer is no, you don't need a Western blot to start, especially when we are always having shortage of reagents in our confirmatory test. Actually, ngayon, we are shifting from Western blot as a confirmatory test to using the RIVDA. So the RIVDA uses three different rapid tests. And that is already a confirmed positive. So if you worried na, wala pang Western blot yung patient ko, can I start? You actually can. Especially if you inform the patient na, okay, because of the urgency or the importance of us starting ARVs, we'll start you na, or will work you up towards that goal, and then the Western blot will be documentation. There will be a risk na posibleng negative yon, which is super, super low risk. No? Lalo na kung may OI na yung patient nyo, malabong negative yon. Pero as long as you talk about this with the patient, na if ever if the test comes back negative, we'll just stop the ARVs. Yan, pwede naman yun mangyari. So it's easier to stop ARVs than to never start it at all and risk losing the patient to follow up. Okay? The timing of the ART initiation, if your patient has OIs, shall be delayed to prevent IRIS. So you've heard about IRIS from Dr. Peñalosa during the TB lecture, and Dr. Sibel Abad during the OI lecture. So ano ba yung mga tamang timing? So sa TB, minimum of 2 weeks. So international studies actually mention na 2 to 8 weeks siya. Depende sa iyong CD4. Pero pag ang CD4 mo ay low, meaning siguro 2 digits and below, 2 weeks ang interval mo from beginning your TB meds, your ARTs after TB meds. But if you have the leisure to wait, pwede rin. So ako, depende rin sa CD4. Pag 2 digits and below, I wait for 2 weeks. If 3 digits or mataas, I can wait for 1 month. Kasi pwede siyang umiris kapag mabilis masyado. Now, pag may cryptococcal meningitis, your ART should be started 5 to 6 weeks after starting the meds for crypto. Pag CMV retinitis, at least 14 to 21 days of the meds, either IV, Gansai, or oral valganciclovir, before you start your ART para hindi magka-IRIS. Adherence shall be assessed and reinforced every follow-up visit to prevent drug resistance and treatment failure. So ideally, ilang percent ba yung adherence ng pasyente mo? Sabi daw 95%. So especially if we are dealing with NRTIs or NNRTIs na one mutation lang, mag-resistant na, kung kayang i-hit yung 95%, let's do it. But if we have the benefit of having the better drugs with a high genetic barrier to resistance, sa kanila, pwede silang mag 80%, especially kapag either protease inhibitors and the second generation protease inhibitors and your integrase inhibitors. Since wala tayo nun masyado, iingat tayo 95%. So, kailangan ba ng CD4 count to start ARTs? So, it says here, it's not required, but because you need prophylaxis for some infections like PCP, which you give at a CD4 level of below 200, important din siyang i-protect by giving prophylaxis. Pero hindi siya dapat hadlang, yung parang, walang CD4 yung pasyente ko, so hintayin ko magka-CD4 before kami mag-start. So, hindi dapat ganon, no? Hindi siya required na. Now, yung pagpa-prophylaxis is adjunctive, it's supportive help, so you can do this. You can do this even at a later date if there is a need to do your ARTs sooner. Ito yung sinasabi ko, na mali yung lagay ng slide. So 95% adherence rate. You should do adherence counseling before, during treatment. So hindi lang, use your form C, your form BC to note if you have areas of intervention for adherence. Next, patients already stable on their current ART regimen shall be maintained on said regimen and monitored accordingly. Ito yung mga available drugs natin sa Pilipinas. So, ito siya. It's important to know yung ano yung recommended first line. So, ang preferred natin ay tenofovir and lamivudine for your yung NRTI. So, ito yung equation, no? 2 NRTIs plus 1 NNRTI. If your patient has an estimated urea clearance of less than 60, ibig sabihin mayroong problem sa kidney, your abacavir is the preferred first line over your tenofovir. So this means your patient should have a baseline urea clearance or creatinine, and then i-compute na lang yung urea clearance. The ideal first line regimen for NNRTIs is efavirenz. Now, if there are some contraindications for efavirenz, like if you have patient has like psychosis or depression, and you think that efavirenz can push your patient into or trigger your patient into having acute events, you can do rilpivirine. But rilpivirine has its caveats, which we will learn about in a bit. So, knowing yung ating local guidelines, ito naman yung guidelines ng ibang bansa. So, sa US, ang kanilang formula ngayon is 2 NRTIs plus an integrase strand inhibitor. So, bongga na sila. It's the era of integrase inhibitors na kasi daw. So, sa kanila, they use TAF. So, TAF is like tenofovir, but it is kinder to the kidneys. So, it's less toxic. So, they use TAF, M-tricytabine, and bictegravir. Yun yung first line nila ngayon. Second line nila is, the rest of the first line is abacavir and dolutegravir, TAF and dolutegravir, and TAF and raltegravir. So, hindi na sila gumagamit ng NNRTIs nor PIs. Insti na sila. Sa WHO, which takes into account yung mga low to middle income countries like us, and yun yung ating pinapattern ng ating yung guidelines din natin, they have either 2 NRTIs plus NNRTI or nag-integrase strand inhibitor na rin sila. So it's either tenofovir, lamivudine, or M-tricytabine and efavirenz. So pareho tayo here. Okay, pareho tayo WHO. Pero meron din silang isa pang recommendation, dolutegravir. So the reason why is they looked at the treatment optimization. So not only is dolutegravir possess a high genetic barrier to resistance, it's actually less toxic. There is a generic fixed drug combination. It now can be used in pregnant. It now can be used in people with TB, and it's actually cheaper. Surprising. The generic dolu, lami, and tenofovir is cheaper than our first line. So ang sabi doon is it's $70 per person per year, pero even lower. So it can go lower. So actually, we're already looking into this if we can bring in dolutegravir, the fixed drug regimen, into the Philippine guidelines. So talks have begun, and I don't know when the next steps will be. So sa WHO, they still have nevirapine. Sa atin, no more na. No more nevirapine. Okay. Now for second line regimens, 2 NRTIs and a boosted PI. We only have one, and that's lopinavir, ritonavir. Now, if you are going to, if your patient needs to shift to the second line, the ideal blind shifting, it means if we don't have any genotyping to guide you and you're thinking of treatment failure, if 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 the patient was previously on tenofovir and efavirenz, magiging Zydo and Lami and Aluvia. And in reverse, kapag Zydo siya dati, magiging Teno, Lami, and Aluvia siya. Okay? So monitoring while on ARTs is lifelong. It requires continuous monitoring, and it requires more frequent monitoring during the first 6 months. Kasi itong first 6 months na to, dito lalabas yung mga toxicities that could affect adherence. Kasi marami kapag nakaramdam na sila ng hindi ka nais-nais sa ARV at hindi sila guided ng treatment provider, they can easily stop the meds. Wala pa silang, hindi pa sila committed kasi first 6 months pa lang. So ito yung ating pwedeng bigyan ng intervention. Paano? By doing our adherence counseling and checking our patients kung nagiging toxic na ba yung drug nila sa kanila. Ito yung frequency of clinical monitoring natin. So, ideally, the patient should be able to do some labs week 2, week 4, week 8, and 12 weeks after starting ARV. Pag stable na siya, pwede nang every 6 months. So ARV drug toxicity monitoring should be done at every visit. And then yung clinical response should be done using viral load. Para kung hindi nagre-respond yung patient mo, kung may treatment failure siya, you can shift. Okay, so when should it be done? So 6 months after initiating ART to detect early virologic failure. Pag stable na yung patient, ibig sabihin, undetectable na siya, pwede na siyang repeat after 6 months. Tapos after nun, yearly na lang. Kasi alam mo na effective yung gamot niya, and kung iinumin naman niya to araw-araw, you can expect na tuloy-tuloy yung kanyang pagiging undetectable. But still, every 12 months, do a viral load to make sure na UD pa rin siya. So when do you require a change of ART regimen? Siyempre, pag toxic yung drug, may unbearable side effects if there are drug interactions and treatment failure. Ito yung mga sample ng toxicity na nag-require ng shift in meds. So, pasyente mo naka first line, LTE. Yung creatinine niya tumataas. Yung creatinine clearance mo pag kinocompute mo, less than 60 na. Then you shift your tenofovir to abacavir. If your patient develops psychosis or other severe events while on ART, pag early adverse event, meaning less than 3 months, refer mo sa ID specialist for further management. Pag late, more than 3 months, consider shifting to rilpivirine. So, ang rilpivirine kasi, before you use it to replace efavirenz in a patient who presents with intolerable CNS side effects or psychosis, kailangan UD siya. Okay? Hindi pwedeng rilpivirine sa simula ng walang viral load. Hindi siya dapat naka-TB meds kasi may drug interaction yon. Hindi siya buntis at hindi siya umiinom ng antacid like omeprazole or ranitidine, famotidine kasi pwede siyang mag-decrease ng efficacy. So important, be aware of all the drugs, whether it's prescription drugs, alternative medicine, herbal remedies, or dietary supplements para i-check mo yung drug interactions. Later on, I will show you a tool I frequently use for checking interaction. Internet lang kailangan mo, and it even has an app. Okay, very easy. Patients on both TB meds and ARTs with adverse reactions to FAV, kasi FAV lang yung ARV na pwede sa TB na wala kang problema. Kaso meron siyang adverse reaction. Refer mo sa ID, hahanapan sila ng kapalit. If your patient has virologic failure, meaning in your 6 months and your 1 year of viral load, hindi siya UD, you're thinking of resistance. So, kailangan mag-send ng specimen for drug resistance. This is called genotyping. It's available at RITM and PGH. Get the blood before shifting. Kasi pag shift mo na to the second line, bago ka mag-genotyping, wala ka makukuhang resistance kasi na-suppress na nung second line yung HIV. Okay, let's do a case. Since nalaman na natin yung mga basic, magki-case tayo. So, kunyari, meron tayo isang pasyente na naka-Zydo, Lami, and Nevi. Kasi hindi pa niya nabasa, yung doktor niya hindi pa nabasa yung guidelines. Hindi niya alam na wala na palang Nevi. Naka-Nevi siya. And yung CD4 ni patient is 450. He now develops an itchy rash and fever. Oops, si Pami. Ibig sabihin may poll tayo. Okay. Wait a minute. Okay. Please answer this poll. What is the most likely source of rash and fever? Is it zidovudine, lamivudine, nevirapine, or all of the above? Please check. Please click your answers. 10, 9, 8, 7, 6, 5, 4, 3, 2, and... Okay. So, ito yung sagot. Tining! Nevirapine. Okay. Very good. Yung mga sumugot ng zidovudine, may pag-asa pa. Pwede rin yan. Okay. So, ito ang common na adverse effect ng ARV natin, rash. So actually, technically, lahat ng NNRTIs pwede mag-rash and NRTIs. Pero ang pinaka sa lahat na pwede pang mag-cause ng Stevens-Johnson syndrome, which means para kang nasunog, no? Pati yung bibig mo, yung mata mo, and all your mucosa, may bahid ng sunog, is nevirapine. Actually, 2011, based on a study we did, we already recommended that nevirapine no longer be used as first-line therapy in the Philippines. Sa study na ginawa namin sa PGH, nakita namin na compared to worldwide, buong mundo sa Pilipinas, sa PGH lang, 18.6% ang nag-react sa nevirapine ng rash versus 6.7. So we have 3 times more allergic manifestations than the world. Ang SJS natin is 5.1 versus 0.3 ng buong world. And there's 100% recovery with switch to efavirenz. So buti naman at na-apply na natin ngayon, hindi na tayo nagbibigay ng nevirapine. So back to the case. So shift mo siya from nevirapine to efavirenz. The rash resolved. However, because the patient is maalam sa internet, he's now anxious about efavirenz. Dami na mabasa sa mga blog or sa mga tweets ng mga taong nakaramdam ng naka-efav. So you want to explain it. So what does efavirenz actually cause? Actually, totoo naman na meron siyang mga central nervous system effects. So, most common in a survey we did in PGH is dizziness in 42%, followed by insomnia, impaired concentration, somnolence or sleepiness, abnormal dreams, and hallucination. So, yun yung CNS effects pa lang. Meron din siyang psychiatric effects. So, sa psychiatric effects, meron siyang severe depression, compared to non-efavirenz users na 0.9%. Suicidal ideation, 9 fatal suicide attempts, aggressive behavior, paranoid reactions, and manic reactions. So it's important to inform your patients that these are the most common side effects, but it's not that prevalent. So compare mo yung central nervous sa psychiatric, kaunti lang. But it does happen, and if you think your patient on efavirenz manifests with depression, please refer to a psychiatrist para they can decide whether it is actually from efavirenz or it's organic, meaning your patient already has depression even from before and nagmamanifest lang siya ngayon. Because I do have some patients who are on efav, but the psych says it's not because of the efav, so they're just on antidepressants. Okay? Now, another possible side effect of efavirenz is it can cause a false positive on the THC or the marijuana, the presence of tetrahydrocannabinol in the urine during random drug tests at work. So if the machine that the drug test place uses is actually modern, it should have negative results na. So, but I still see some patients na kung saan sila nirefer sa work ay nag-positive. So, they go to PGH, sa FMAB, they have better, and maybe other drug test places na negative doon. So, what they do is they will show the negative test with a positive, and sometimes they get a letter from me stating na he is on some medications that can cause a possible false positive. So, yun. Para lang alam niyo. Now, after 2 months on Zydo, Lami, and Efav, naging Edward Cullen na yung patient mo. So, pale na siya, lightheaded, gets tired easily with palpitations. So, on PAMI says we have another poll. I think this is the last poll. Ay, mali. Ano ba yan? Sorry, XXXX. Here we go. Okay. So, what is the most likely reason for this? A, anemia from zidovudine. B, stress from all the side effects. C, vomiting from efavirenz. And D, anxiety from frequent doctor visits. Please key in your answers. 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. Okay, so ito yung result natin. So very good, no? Anemia from zidovudine. Pwede ring stress. Anemia is the most common cause of this Edward Cullen-ish look. So nagpa-CBC ka. Oh my gosh, hemoglobin mo is 75. Okay. So this is why monitoring for ART toxicity is important. So if your patient is on zidovudine, CBC should be done at weeks 2, 4, 8, 12, 24, and every 6 months or as needed. If your patient is on tenofovir, creatinine should be done within 6 months and every 12 months. If your patient is on efavirenz, because it can increase your cholesterol, especially your LDL and your triglyceride, you do a baseline lipid profile and then 6 and 12 months and then as needed. If your patient is on ropinavir, ritonavir, because it can increase fasting blood sugar, triglyceride, and LDL, you can do a baseline lipid profile, FPS, and then at 6 and 12 months or as needed. Now, so sniff mo na yung pasyente mo, 2, 3 in 1, Teno, Lami, Efav. Now what? So we have to know anong posibleng side effects. Meron na bang resistance yung patient ko kasi nakailang palit na kami? And what is available in the future? So tenofovir adverse reactions are the following. So if your patient has Hep B, sabihin, HBsAg positive siya, hindi mo pwedeng biglang i-withdraw or i-stop ang tenofovir because baka mag-flare. That's why nagbe-baseline HBsAg tayo. If your patient has increased CREA, proteinuria, hypophosphatemia, everything that looks like a Fanconi syndrome, you should be able to monitor kidney function with your nephrologist if possible, or maybe shift to something more kidney friendly. Now, sabi nila, tenofovir also puts you at risk for osteoporosis because of decreased bone mineral density. And this is evident as early as 6 months. So even with PrEP users on tenofovir, we should inform them that tenofovir actually causes this. So if your patient can afford, you can suggest a BMD, yung dito lang sa kamay. But it's not really that cost effective. So basta alam na ng patient natin na meron silang may effect ng tenofovir na ganito. So just in case, no, ito na yung other options mo, yung protease inhibitor. So you should also be aware of the adverse effects of RPI. So most important dito is your cardiovascular disease. So increased risk of MI or myocardial infarction or heart attack or stroke, increased insulin resistance which can lead to diabetes. So yung increased LDL, increased triglyceride, increased HDL, and then yung acute side effect niya is the diarrhea. Okay, day 1 pa lang may diarrhea ka na. Nausea and vomiting. Yan yung number 1 kailangan sabihin na huwag kang magulat, bigla ka na lang magkakaroon ng urgency to poop. Hepatic effects. Lipodystrophy, prolonged use of alluvia or lopinavir-ritonavir can actually cause wasting. Lipohypotrophy. Nawawala yung fat content ng face, ng arms at legs, at napupunta siya sa tiyan at sa likod. No? Yan, lipohypertrophy. Nagiging mataba sa gitna. Okay. So what can you do? Prepare mo sila. Kung ikaw yung counselor, no? Kung counselor ka at pupunta pa lang sila doon sa clinic ng doktor at alam mo na it's time na mag-enroll ng ARTs, tell them to ask the doctor the following, and doctors naman, be prepared to answer these questions from your patients. No? What's the name of the drug? May mga pasyente hanggang ngayon hindi pa alam yung pangalan ng gamot nila. Learn the drug's brand name and generic name. What it's supposed to do, you can show them the HIV life cycle if you want to, and then say it acts here and here. When do I take it? What's the best time of the day to take it? Before bed or first thing in the morning? Should it be taken with or without food? Are there any food or drink I should avoid when taking the drug? Are there any medications I should avoid when taking the drug? What are the most common side effects? Is there anything I can do to reduce the side effects? Are any of the side effects serious? Should I call right away if I get a certain side effect? Should I stop taking this drug if I get it? Etc., etc., etc. Now, so it's also needed to, kailangan siguro magbigay tayo ng mga first aid tips, no? If they begin feeling a side effect. So once you instruct the patient on your ARVs, dapat may baon sila na parang, okay, if you feel this, you should do this. Para hindi sila lost. Know when to come to the clinic or go to the ER para guided sila. So I will share the slides with you so you know in summary all of the side effects of the ARVs that are in use. Kasi super dami. It'll take a long time to discuss everything. But I'll just share this. So ito yung sabi ko pala. So go to, oh my gosh, i-google nyo yung HIV drug interaction, University of Liverpool. Sa app, it's called iChart. I have it on my app also. And here you can actually see if you have any drug interaction with your HIV meds plus the co-medications. It will tell you kung potential interaction, need to stop the meds, ganon. And it will tell you why. May scientific explanation siya. So super helpful na to. Now, so we talk about the basics and now saan tayo papunta sa future? So if we see here, nakabox yung the Insti era. Actually, delayed na nga. Wala pa tayo dyan. Dito ba tayo sa single tablet regimen? But the rest of the world is already moving forward. And actually, we're already testing the long-acting injectable ARVs para, in line with our treatment optimization, increase ang kanyang genetic barrier resistance, no pill burden at all, and easy. Kasi hello, hindi ka na pupunta sa clinic araw-araw. Okay, so here we are now, the evolution of the ARV drug pipeline. We had new drugs, Bictegravir, which is now the first line in the US. We have a new NNRTI, the Raverin, and then we're still using Zidovudin, which is the first ARV drug. So, ganyan talaga, pag low to middle income country, we have the same problems, we have the same issues as our neighboring countries in Indonesia, Thailand. Yung iba meron ng bagong gamot, yung iba parehong-pareho sa atin ng sitwasyon. So, it's not as easy as we think to get new drugs inside the country. And these are our potential game changers for long-acting HIV treatment. What's already approved by the FDA is ibalizumab. It is a monoclonal antibody. It's given twice a week. It's injectable. All the rest are still in phase 3 or phase 2 studies. So let's just see where that takes us. Okay. Ito yung mga ongoing reduced drug regimens. So we have long-acting rilpivirine and cabotegravir. It's showing pretty good results with regards to suppression. It's still not available in the market. So I think last few slides as we close our session. The drug optimization key principles are, if we have the bandwidth to choose our medications, it should be not toxic. It should be easy to take. It should have a good resistance barrier. There should be less drug interactions. It should be safe to use across different age groups and populations, and it should be cheap. Okay? So ito yung sinasabi ko na hindi mahirap magpasok ng gamot sa bansa. So it means a lot of stuff which our leadership in the HIV program are actually going to have to do. So let's hope that because we're starting the conversations on bringing in new meds, that we will be able to see some changes in our regimen in the future. Remember that ARV is only one aspect of the super complex HIV management, but it is a basic competency for the healthcare provider. And I hope that with this session, we have gained some more insights into ARV so we can inform also our patients and let them know, be familiar with what they're taking so they can actually they are invested in their healthcare. I think this is the last slide, and thank you for your attention.